Hello, I'm Dr. Vladimir Maletic. I'm clinical professor of psychiatry at the University of South Carolina School of Medicine in Greenville, South Carolina. I wish to welcome you to episode 3 in a series of 4 podcasts on bipolar depression entitled Individualizing Management of Bipolar Depression Tips on Providing Patient Centered Care. My esteemed guest today is Brooke Kempf. She's a psychiatric nurse practitioner at Community Mental Health Center in Terre Haute, Indiana, as well as adjunct faculty at Indiana University and Purdue University in Indianapolis. Welcome, Brooke.
Thank you, Vlad. Thank you. Glad to be here today.
So, topic of our conversation this morning is personalized care. We have several approved choices for treatment of bipolar depression. I'd like to ask you, how do you discuss these different efficacy and side effect profiles of medications for bipolar depression with your patients? How do you start this conversation?
Yeah, I think this is a good start to our conversation. I think we really do a good job in psychiatry when it comes to educating our patients on treatment options and side effect profiles based off if we're talking about bipolar 1 or bipolar 2 depression. But in talking about different options with my patients, I remind them every medicine we try has a potential for a side effect, but I start off with if we're had like that one number one side effect that would be an absolute deal breaker. I will not take a medicine if it causes X, Y, or Z. That's kind of where we start. So several start with things like weight gain, or if I have a busy professional or parents, they often say I couldn't deal with sedation. If I have patients that have had bad experiences before with something like akathisia, they might put that at the top of the list. It at least gives me a starting point. So we've established a diagnosis, we look at evidence to support the use of these different medicines, we go through the common side effects. Obviously, there's going to be some outliers, but starting with the most common allows me to educate them, and we can make a decision based off of their deal breaker. So if they're telling me no weight gain, I'm going to avoid medicines that cause potential to cause more weight gain, such as the quetiapine, the olanzapine, fluoxetine combination. Now, I might avoid those also due to somnolence, but there's some medicines like lorazepam or lumateperone. They might cause some somnolence, but they're less likely to cause the weight gain. And sometimes I actually use the side effect to my benefit. So if poor sleep is a major complaint, I might choose one of those options and actually use that as our benefit. I try to take into consideration of dosing of medicine too. Sometimes an increased side effect such as EPS or akathisia might occur with higher doses of lorazepam or cariprazine. So sometimes we can treat a side effect just by adjusting the dose, especially if we're getting benefit and we don't want to give up on the medicine. But at the end of the day, it's all about weighing the risk and benefits of medicine. And patients have the right to make an informed decision. And I really, truly believe it's our responsibility to review the options with them and let them make a decision. But I assure them too, I'm going to be monitoring you along this treatment journey. We'll watch for these side effects, but I also need you to tell me if you're having a side effect before stopping the medication. They really have to be part of the decision making because adherence can definitely be affected by a side effect. Patients don't want to take medication if they can't tolerate a side effect.
Well, thank you very much for such a detailed answer. Now, you've partially already answered my next question, but it has to do with common psychiatric and medical comorbidities of bipolar disorder, more specifically as it influences choices of bipolar depression treatment. So, if the patient, in addition to bipolar disorder, let's say depressed phase, has an anxiety disorder or insomnia, or they have a metabolic syndrome, how would that influence your choices? What kind of conversation would you be having with your patient?
Sure. But that's not uncommon, is it?
No,
Our
no,
patients
no.
already have a multitude of comorbid medical conditions. I know probably one of the most common issues I run across are metabolic issues. When I think about other medical comorbidities, like you mentioned, the insomnia or anxiety, sometimes side effects of medicines can either add to those like akathisia. Patients don't know how to describe akathisia, so they might describe it as anxiety, feel like their anxiety is becoming even worse. So sometimes we have to narrow that down. But like I mentioned, probably metabolic issues are the ones that I come across the most. My patients are obese, they have diabetes, hypertension, hyperlipidemia. So I try and avoid medicines like quetiapine, the olanzapine, fluoxetine combination, if those things. But I not too long ago I had a patient on our inpatient unit. She had back-to-back admissions, diagnosis bipolar 1 depression. And when she came into the good thing about being in community mental health, you often have access to records, and I could see the different medicines that she had tried, and things were just not effective. Individuals were trying to utilize medications less likely to attribute to her medical comorbidities. She was diabetic. Uh, I don't remember exactly what her BMI was, but she was overweight. And so, in choosing different treatment options, unfortunately, after everything she'd been on and had not successfully done well were on, we decided to use quetiapine. And actually, she was sleeping better. She was participating on the unit. Yep. She gained a couple pounds while she was up there. But before she came in, she actually wasn't eating and, not bathing, not taking care of herself. So actually, that was kind of a positive sign. We monitored her blood sugar every day while she was up there. And we're talking blood sugar remaining under 100. So we just provided her with a lot of education behind that, which she already knew a lot from her diabetic history, but she went home on quetiapine, much improved, but only to return not too much later because she had gone to primary care. Primary care just sees quetiapine listed on her medication list and immediately told her she shouldn't be taking that medication because of her diabetes. So she just stopped. That she was not then taking anything for her bipolar depression. She ends up back in with another hospital stay. So we have to do this big consultation, figure out what are we going to use. And even the patient felt she did best on quetiapine. So we went back to it, but I had a direct conversation with the primary care provider. We kind of work as a team and come up with a plan to help the patient best benefit in both worlds symptoms, but then also addressing some of those comorbidities. So sometimes it's a fine line.
I really like your approach because although we do have information about general adverse reaction profiles of these medications, it's not a law, it's not a hard rule. And sometimes we do need to personalize care for our patients, keeping in mind balance, primarily of efficacy, but then also adverse reaction profile. And would it be manageable in a given patient, especially if one invests time and provides some education like you just did?
Exactly.
Let's go to another very common scenario. So let's say our patient has bipolar 1 or bipolar type 2. They have been treated with lithium and valproate. Now they're in the midst of a depressive episode. Despite the mood stabilizing agent being on board, it seems like we need to consider some other treatment in order to help them in depressed state. What words of wisdom and guidance would you have for your patients at this point?
Well, first and foremost, I'm going to check for adherence. It's easy with these medicines. I can get lithium or valproate levels and make sure that adherence isn't the key problem. I can also check for those underlying issues, like checking their thyroid functioning. But if all that's in check, I'm going to augment with an atypical antipsychotic. But if you look at the evidence, it's not like we have a lot to choose from that really supports the use of augmentation for bipolar 1 depression. We have lumateperone or lorazepam. But if it's bipolar 2 depression, the only thing we actually have FDA approved for adjunctive treatment is lumateperone. So I know as clinicians, we can make decisions and we can absolutely augment with other items, but I would at least follow the evidence and start there. So again, adding probably adjunctive atypical antipsychotic, probably starting with lumateperone due to the evidence.
Yeah, yeah, I really like your reasoning because you're not being dogmatic, right? What you're saying, we do have a number of alternatives, but let's start on the firm ground. Let's start with agents where we have evidence supporting not only efficacy but also safety in particular phase of bipolar illness, and where there is evidence of efficacy as adjunctive treatment. I really like that. Another relatively common scenario that we encounter when treating bipolar depression, mixed features. So these are patients who will have, in addition to a depressive episode, three or more hypomanic or manic symptoms. How do you approach their treatment then? And how do you educate them? Many of these patients, because they're depressed, they're thinking that they should be on antidepressants. Uh,
Exactly.
how do you begin this conversation?
Exactly. Well, and as you mentioned before, it's never a hard no, but I really, really try to avoid antidepressants when it comes to treating bipolar disorder. I know we have the exception with the fluoxetine olanzapine combination, but we have data that shows bipolar depressed patients with predominant manic symptoms treated with antidepressants are more likely to flip to mania. So I do try to avoid them, but looking at actual data for bipolar 1 depression with or without manic symptoms. Cariprazine has a post hoc analysis where symptoms were significantly improved versus placebo. We also have lorazepam with bipolar 1 depression with the mixed feature specifier has a post hoc analysis also showing significant improvement versus placebo. Lumateperone has a post hoc analysis showing significant improvement compared to placebo in both bipolar 1 and bipolar 2 depressed patients with mixed features. Quetiapine has positive data, but it's a small open label pilot study with high dropout rates, but it does have a signal for improvement. But when looking, patient specific, as you mentioned, patients feel like they need to be on an antidepressant. That's what they've been told. Not too long ago, I had a patient on our inpatient unit who had come in. She came in with the diagnosis major depressive disorder and generalized anxiety disorder. And when I'm looking at this patient and gathering this information, I like on an inpatient unit, I have the time, I can sit down, get this clear history, get information from the family, really after picking through the weeds. So when we went back and we kind of clarified the information, her daughter really was able to give me this clear history of her having these specific episodes where she's kind of just all over the place. She's not taking care of herself. She's showing up to babysit not her usual self, not dressed appropriately, like she's wearing pajamas and hasn't showered. And that's not at all this usually well kept individual. So, after again gathering all this information, we had diagnosed with bipolar 2 depression with mixed features. And actually, when we went through these treatment options, she was relieved. She had been through a gamut of different antidepressants. She had had some adjunctive treatment. I think they tried aripiprazole for adjunctive treatment. She tried all these options and was not getting better. Might get better for a little while, but never felt well. So when I was able to tell her, I think we might be dealing with a different diagnosis. Let's come up with a different treatment plan. She accepted this bipolar 2 diagnosis and was actually like, okay, maybe it wasn't me after all. Maybe there's hope that we could do something different. We were planning, I think she came in on venlafaxine, and we were initially with that original diagnosis, we were going to try and increase it, but we titrated her off that and actually started her on lumateperone while she was up there. And she responded well. I think we started with lumateperone because she did not want weight gain. She had had some akathisia with aripiprazole in the past, so we had chose that, and we really did see her getting better. But she emphasized, I feel like I need an antidepressant with this because I've always been told to treat my depression and my anxiety both. I have to be on an antidepressant. So after giving her the appropriate education, she was able to understand I can get actual treatment for depression using this atypical antipsychotic. And we got her much improved back home and hopefully functioning back to her baseline.
Now, a final and unfortunately all too common scenario. You're seeing a patient with bipolar depression, and in addition to having bipolar depression, they're reporting lack of enthusiasm. They're not motivated. It's hard for them to initiate activities. And even if they are able to overcome this emotional inertia, so to say, and go out and socialize, they'll report that they're not really having a whole lot of fun. Do we have anything to offer to those
Yes,
patients?
anhedonia. Yeah, oh boy, I anhedonia is that gift that just keeps on giving, isn't it? It can be so difficult to treat, and it really is. It plays that big factor on patients getting better, but not getting well. They may be getting back to work, but they're not productive. They may be showing up at the kids' games, but they're not cheering. They're not enjoying it. So it is that one level that often keeps us from getting to remission. And, data shows that bipolar 2 depressed patients have more pronounced anhedonia even than major depressive disorder patients. So, looking again for evidence that supports, what's out there that we can really kind of target this difficult to treat symptom. Cariprazine actually demonstrated antidepressant effects in bipolar 1 patients with or without anhedonia and had an anti-anhedonic effect when adjusting for other depressive symptoms. And then lumateperone specifically looked at anhedonia symptoms in the MADRS and showed significant improvement from baseline at like day 43 versus placebo. And then there's these other treatment options that, kind of new to me out there. Glad you may have experience with these, but pramipexole, which is a D3, D2 partial agonist, infliximab, which is a TNF alpha antagonist, ketamine, which we might be a little bit more familiar with, and then MDA antagonists show reduction in that specific anhedonia in bipolar depression. So I'm always excited about seeing some of these little outliers and things that might have some data because, like I said, this is one of those things that can keep our patients from getting to remission. So I am all open for new things out there.
So I really appreciate your summary. So there are a couple of agents that are approved and do have evidence, such as cariprazine and lumateperone. But then there are some treatments that are considered more experimental, where we do have preliminary evidence of efficacy for anhedonia, such as anti-Parkinsonian agent pramipexole. But it's also interesting. Inflammation tends to be associated with anhedonia. So infliximab, which is a TNF alpha inhibitor, also has again some preliminary evidence suggesting a benefit in bipolar patients who are depressed and have pronounced anhedonia as well as ketamine. So you're really offering a lot of choices for our patients. Uh, just before we conclude our brief conversation, Brooke, do you have any last words when it comes to treating patients with bipolar depression? Any pearls of wisdom that you would offer before we close?
Yeah, I do. At the end of the day, it is a definite team approach. You and the patient are a team. They need to know what the options are out there. They need to be part of that decision making. They need to be well informed so they know what to expect. They know how to communicate with you. But then we also have to communicate with the rest of the treatment team. So it really does take a village. And I think the more education, more communication we have with our patients, hopefully better outcomes.
Thank you so much, Brooke, for joining us today and sharing so much of your clinical experience and wisdom with our audience. And I would also like to thank our audience for joining us today. And I hope that you will stay tuned for our next episode on bipolar depression. Thank you very much.